Milind, would you like to say a few words before we move on to the...
Hello, everyone. Good morning. Good morning, Manpreet sir, and good morning, all speaker. On behalf of VOS and OSN and Nagpur Plastic Association, we all welcome you for a interactive webinar session on DCR. So this is our second session. We will be talking about the endoscopic diagnostic approach and how ophthalmologists can move on from external DCR to endonasal DCR, and it can be done, and many people are practicing this type of practice nowadays. So Dr. Manpreet is available from PGI Chandigarh, and we have a speaker Snehal Kokade. She will be talking about the instruments, specialized and routine instrument in the DCR. So, Dr. Shivani, over to you for an introduction of speakers and our guest. Thank you.
Yes. So, good morning, everyone. I'll just start sharing my screen. So, before we move on to the top discussions of today's, I'd like to give a brief introduction of all the panelists which we have, as well as the speakers and our guest speaker. So, I hope my screen is visible to everyone now.
Yeah, ma'am.
Okay, right. So as Milind said, this is our second webinar on the entire series of cadaveric DCR workshop. And this is going to be our today's agenda, which Milind has already briefed us about. We have very esteemed two panelists with us. That is Dr. Chitra Pandey, ma'am, who's a postgraduate from Government Medical College, Nagpur. She's a senior consultant and oculoplasty surgeon at Mahatma Eye Hospital. She's been teaching and guiding DNB students since 2012. And she also has her own setup by the name of Akanksha Eye Care Center at Nagpur. Then we have the second esteemed panelist, that is Dr. Anup Chanda. He is an MS Ophthalm from, I think, Arvind Eye Hospital, and he has also done it from Bangalore. He's basically practicing as a consultant phaco as well as an orbit and oculoplasty surgeon at Amravati. Then coming on to our today's first speaker, that is Dr. Richa Dharappa. Richa is a DNB FICO oculoplasty, and she has done her graduation from TNMC Nair, Mumbai, and her post-graduation from HV Desai Eye Hospital, Pune. She's a long-term fellow who's done her ophthalmic plastic surgery from LV Prasad Eye Institute, Hyderabad. And presently, she's working as an oculoplastic consultant at Government Medical College, Nagpur. Richa says that her hobbies are singing. I've seen that she's a lovely singer, and she loves to do photography as well as explore new avenues in the kitchen. The second speaker for today is Dr. Snehal Kokade. She's a graduate from GMC Latur and a postgraduate from Sion, Mumbai. And she has done a fellowship in oculoplasty and ocular oncology from HV Desai Hospital, Pune. She's been teaching in the field of this teaching since the last 10 years. And Snehal also loves to visit historical places, cooking, and dancing. Then coming on to the guest faculty of today's, that is Dr. Manpreet Singh. He's an associate professor, Department of Ophthalmology, a postgraduate institute of medical education and research, that is PGI MER Chandigarh. And he's known for his versatility and dynamic surgical skill. He loves teaching. He has, by God, more than 101 publications to his name, along with multiple presentations in regional and national conferences. And this is an enviable list of all his degrees and achievements in the past many years since 2019. So let's begin with our first talk. This is more than enough from my side. So I request Dr. Richa to present with her the topic of today's discussion.
Very good morning to all. Thank you so much for the kind introduction, Dr. Shivani. Let me just share my screen. All right. Is my screen visible?
Yes.
Yeah.
Yes.
Okay. All right. So today I'll be talking about nasal endoscopic examination. we will have a look at this I have no financial disclosures. We'll have a look at this in the form of 4 parts. The basic textbook anatomy, or something that we already know and I would like to brush up upon. Then we would look at the normal in vivo endoscopic view of how it is to actually put the endoscope into a nose. And then we look at some variations. So for this third part, I would like all the participants to have a pen and paper with them. I have a small question-based system for you over here, where I'll show you some variation and I'll ask you a small question about it. And if we have time, we can just put it up on the chat and discuss it. And the last one is looking at the new normal, which is the DCR ostium after the DCR surgery. So textbook anatomy, since first MBBS, we have looked at this picture, but today I want to show you something one more step ahead. So these are the pictures of the cadaver. This is basically the lateral nasal wall of the left side after the septum is being removed. We'll be having a look at this during our cadaver workshop as well. So you all will have a chance to understand this better during that time also. So I have labeled these inferior turbinates, middle turbinate and superior turbinate. This is basically, we have just removed the septum and we are viewing the lateral nasal wall as it is. The anterior end of the middle turbinate is where the anterior end attaches to the lateral nasal wall is known as the axilla. And that is an important landmark for us to begin our DCR or any lacrimal surgeries via endoscope. The steel probe that we can see is actually entering the middle meatus over here. So this is just a picture from the external aspect, from the orbital aspect of our bones. And Dr. Shivani has beautifully illustrated and explained this last time. I would just like to quickly take you through this once again. So our lacrimal sac fossa, where our lacrimal sac sits, is formed by 2 bones, the frontal process of the maxilla and the lacrimal bone with a suture within it. Now the lacrimal bone, as we know, is a very, very thin bone. So what I'm coming to is basically this thin bone is being is showing transillumination through the opposite side over here. And this brings me back to our first slide over there, which was talking about the axilla. Okay, so now if you can notice, can you see my arrow? If you can see, this is the part of the axilla which is actually opened up. And we can see the transillumination through the lacrimal bone very nicely. So that is what I was trying to show. Ki lacrimal bone lies near the axilla, that is near the anterior end of the middle turbinate, which is our area of interest throughout our lacrimal surgery. All right. So now moving on, we will now remove these turbinates and see what is beneath it. Of course, it is the meatus. So inferior, middle, and superior meatus. You can see a probe being seen in the inferior meatus. That is basically the opening of the nasolacrimal duct. A probe has been passed through the entire lacrimal system and it is coming out through the normal opening of the nasolacrimal duct in the roof of the inferior meatus. So this is what it is basically showing in this picture. This we have gone one step further. After removing the meatus, we have also removed the lateral bones over here. After removing the lateral bones, all we have is the entire intact lacrimal sac and the nasolacrimal duct. So the superior bulbous structure that we can visualize over here, this is the lacrimal sac in its place, in its fossa, but we have removed the fossa over here from the nasal aspect. And this is the nasolacrimal duct, this tubular structure, and they are sitting in their own anatomic position right here. We have just removed the bones to expose them and to show their relationship with the meatus and the nasal aspect of the structures. All right. So this is the middle meatus that we are looking at. So just to give you a better understanding, this is the inferior turbinate over here. The inferior turbinate has not been removed at all. Okay, so that is normal lateral nasal wall. Then iske upar jo superior middle turbinate which is normally present, that is removed to expose the middle meatus. Now there are certain structures in the middle meatus that we should know and we should be careful about, because they can have variations in their anatomy and they can actually obstruct our surgical site in certain scenarios. So this, what is being held by the forceps, is an ethmoid bulla. Now, the ethmoid bulla is the largest air cell of the ethmoid sinuses. It is usually present in the middle meatus. And iske just niche, if you can see, there is a sharp line over here. This is the uncinate process. So these can sometimes be enlarged, or these can sometimes really obstruct our views and reach up till here. So this is why we need to know where they lie and what they do. Second one is this M line. If you can see this vertical soft tissue line over here, this M line actually represents the nasolacrimal duct junction and its opening. So sometimes if the axilla is not visible, then we can use the M line to actually go ahead and make our incisions for our lacrimal surgeries. This is the agonasi. This is also present in the middle meatus in the superior portion. This is actually related to the opening of the frontal process within the middle meatus, but it is the anterior most ethmoid air cell. And because it is the anterior most ethmoid air cell, it can sometimes sit very close to the axilla and very close to the middle turbinate, where the middle turbinate attaches to the lateral nasal wall. And this could interfere in our surgical site, as we might see later on. And this is the lacrimal sac over here and the nasolacrimal duct. All right. So coming to the last couple of pictures over here, the star mark is showing the lacrimal sac. Now this is the middle, this is our medial wall of the orbit that is being seen from the nasal aspect. So this is basically the ethmoid bone, the lamina papyracea as we call it, the thinnest bone. Okay, so why do we need to know this? Is because if we have proceeded from dissection in this area and gone a little bit more posterior, we need to know what we can encounter posteriorly. So naturally, if this is the medial wall is also very, very thin. So in case it perforates, because normally we need to remove the lacrimal bone, which sits right here. But in case in vivo, sometimes it is not understood, or sometimes because of the variations, the depth cannot be perceived well, then the medial wall can also be punctured by mistake. And if this happens, then we are going to start seeing fat within our surgical site. So if there is visibility of fat in the surgical site, you have gone to posterior and you need to come a little anterior to search for the lacrimal sac. Of course, if you're doing an endoscopic or vital surgery, then you need to see this fat to actually address the orbit. All right, so coming to our in vivo pictures now. Now, there are 3 nasal endoscopy passes. So the way we hold the endoscope and pass it within the cavity is very important to know what structures we are going to see. So when we go parallel to the floor of the nasal cavity, we are having a look at the inferior turbinate, the floor, and the posterior structures. When we tilt it a little and we are facing the middle meatus area, we are actually looking at the anterior end of the middle turbinate, that is the axilla, the middle meatus, and our area of interest, the lacrimal sac area. And the third pass is related more higher. So that is at the superior meatus and the sphenoethmoidal recess. Of course, this pass is something that we usually don't look at. We deal with the first and second pass most frequently. All right. So I just want to explain that when the patient is lying down, this is how the nasal cavity will actually look like. So when our endoscope is completely perpendicular to the floor that we are standing on, we are actually looking at the floor of the nasal cavity. So we are looking at the inferior turbinate and the middle meatus and the inferior meatus. But when it is parallel to the bridge of the nose, that is when it will be looking at the middle meatus. So we'll have a look at this through a short video. So we are now completely perpendicular to the floor we are standing. Okay, we have gone inferiorly. This is the inferior turbinate. This is actually a patient in which we are performing suctioning in the nasal cavity after DCR. So these are the posterior structures. That's the posterior choana that you can see. Okay, that opening. You can see the posterior pharyngeal wall and the eustachian tube. This is the far end of the posterior aspect of this inferior pass. Now this is the inferior turbinate being lifted by a periosteum elevator, and we are exposing the inferior meatus over here. So we want to visualize this in cases of congenital nasolacrimal duct obstruction. When we want to see the nasolacrimal duct, this is the roof of the inferior meatus. We are inside the inferior meatus now. The balloon that was actually dilating the nasolacrimal duct is this, and we can see a very nicely dilated opening. Now this is the second pass. We essentially are parallel to the dorsum of the nose over here. So when our endoscope is held parallel to the dorsum of the nose, we are going to see more superior structures. So this is the middle turbinate, inferior turbinate, septum and lateral nasal wall. Naturally, this is the left nasal cavity that we are having a look at. This is obviously without decongestion that we are seeing. This is a little more broadened cavity. You can see the anterior end of the middle turbinate is a little bulbous over here, but it's the left cavity only, with the septum, middle turbinate and the lateral nasal wall being very well visible. Now when we go into the middle meatus here, we can notice that there is an ethmoid bulla, the uncinate process, that is a sharp line below the ethmoid bulla. Alright, and this is basically our site of interest, that is the middle turbinate, as you can see, the axilla, which is the anterior end of the middle turbinate, the M line, which is where we would make our incision, anterior to which we can see a small aga nasi there, as well as a small ethmoid bulla. So these at the present site are not going to really trouble us during our surgery. So now coming to our third part, looking at the variations. Now, if all of you can just take a pen and paper and maybe we can have a look at this. So the first one is over here. We enter this cavity and we are seeing something like this. Okay, so I would just like to ask, which cavity is this? Can you just write down which cavity is this? Maybe you can put it in the chat box. Okay, that's the first picture. The second picture is this one. So this is a very large middle turbinate and we are trying to punch. We've opened up the nasal mucosa here and we're trying to punch, but we just cannot put our punch through. In the area that we normally expect, the punch will go very, very easily. So then we go ahead and try to go even more posterior, and there you go. Now we can finally punch. And you can see that initial opening is so much more posterior to the anterior end of the middle turbinate here. So which cavity is this, and what is the variation over here? This is the third scenario, where we can see two bulbous structures, if you can notice. So these are the two bulbous structures over here. So what are we likely looking at? And this is the fourth scenario. Which cavity is this, and what are we likely looking at over here? Dr. Shivani, Dr. Milind, do we have 2 minutes to discuss this, or should I just carry on?
No, you can discuss. You do have time.
Okay. Okay, so then is there any response on the chat?
Just check.
Okay, can anybody put it up on the chat what the first picture is showing? Which cavity is it? Can you at least tell me that much? Which cavity are we dealing with in each of the pictures? Even if you can point out that much, it would be great.
Yes, Dr. Ankur is saying that it is third ethmoidal air cell.
In the first picture, you mean? Okay. In the third picture.
I'm sorry, it's
third picture.
Third picture, yes.
Okay, the third picture is ethmoidal air cell. Yes, it is an ethmoidal air cell. Can you tell me which cavity is it?
So he gets half.
Anyone can answer that, no problem. Because till you don't understand which side of the nose we are seeing or which cavity we are seeing, you know, the understanding. All right, anybody else wants to try the first, second, and fourth picture?
Anyone else? Or do you wanted to reveal what it is exactly?
Yeah, we'll wait for maybe 30, 40 seconds, or else I'll just go ahead.
Yes, yes.
Anyone else, just take a guess. It's okay if you're right or wrong. We're all here to learn. So
Richa, you can play the videos again, I think, probably.
all right. All right.
If you really want to get the people's response.
Okay. Okay. So this is the first one. So this is something we're seeing as soon as we put in the scope. This is something we see. This is the second one where we start operating. We've trimmed the nasal mucosa over here. We see the bone. And routinely, our punch should easily enter this area, but it's not. So we have to go even more posterior in this case, trim more mucosa, and then we've gone way more posterior than we expect. And then we finally get to insinuate our punch.
So, Richa, we've received one more answer.
Okay.
The first picture is inferior meatus is Dr. Ankur's reply.
Okay. Fine. All right. We'll come to that. Okay. This is the third picture. He has already answered it that it is an ethmoid air cell, but I would like to be more specific over here. So these are the two elevated mounds that we are seeing, and I want to explain to you what that is in the subsequent discussion. All right, and this is the fourth scenario. So what are we looking at over here? Okay. So coming to the first one, this is the left nasal cavity, and we are seeing the ethmoid bulla in the first picture. So what looks like to be the middle meatus, okay, is actually not the middle meatus. The middle meatus is sitting right here, if you can see.
Turbinate.
This is the, middle turbinate.
Yeah.
Yeah.
Observe.
And then when we actually retract the ethmoid bulla is when we can see this. The ethmoid bulla needed to be passed through to actually enter the sac in this particular case. I'll just show it to you once again. So this is the anterior end of the middle turbinate here. So we can easily mistake this for the middle turbinate and then start our incision anterior to this, but we're not going to get anywhere. We actually need to open this up because the sac, this is kind of a sac and sinus picture over here. So after we open the ethmoid bulla, we see the lacrimal bone over here. And after removal of the lacrimal bone, you can appreciate the lacrimal sac. This is the second picture. This is the right nasal cavity. And this is a concha bullosa. Concha bullosa means nothing but the expanded air cell within the middle turbinate. So this is the air cell within the middle turbinate out here. That is why it is so enlarged. And that is why it is protruding much more than it should. So naturally, it is so large and it's going to weigh down on our surgical site. So in this particular case, after performing our first punches and we realize that this opening is very much posterior to this entire set, we need to address this. So we do a middle turbinoplasty over here. After opening the mucosa, we actually remove this air cell. We decompress that area and we even trim the mucosa a little so that it comes in level with our surgical site, so that it does not fall on our surgical site and cause any failure related to that. Right? So that is a concha bullosa where we need to do a middle turbinoplasty. All concha bullosa do not require a middle turbinoplasty, but this particular one did. This is the third scenario. So this is a right nasal cavity again. And this is a pneumatized agar nasi. So we had discussed agar nasi is the anterior most ethmoid air cell. Now, if it is largely pneumatized, it is going to appear like this. So we can see the axilla. So initially I tried to take the incision over the area that we would expect, but it wasn't going as per plan. So then I had to actually address this. This is also kind of a sac and sinus picture. So then once we address that and open up the agar nasi cell is where we start seeing our lacrimal bone. There you go, that's the sinus. And when we remove this, now we can see the sac that is actually lying within the sinus over here. All right, the fourth scenario is simple. This is the left nasal cavity. This is the middle turbinate. This is actually a post-FES picture, meaning the ethmoid sinuses are exposed and open. So these are all the ethmoid sinuses that you can see, the insides of the ethmoid sinus. So over here, it might look a little different, but you need to carry out your surgery as usual. You need to take the incision anterior to the axilla as you normally would. And this usually does not interfere during your surgery. There you go. Our surgical site is actually quite anterior, and you can see that I'm pressing the sac from outside, and you can see it is quite anterior to the entire ethmoid process. Okay, so coming to the fourth part is the DCR ostium, which I would call as the new normal. So any case of DCR surgery is going to have a DCR ostium that you would want to evaluate endoscopically. So just briefly, this is the middle turbinate. This is the anterior end, the axilla. And this is our surgical site, where we have performed surgery. Now, you have seen in so many pictures and videos in the past. So we look at the DCR ostium as an anterior, posterior, superior, and inferior edges. It has a base. The base can be elevated. It can be shallow or deep, depending on the anatomy again. And the probe is actually passing through the common canalicular opening. This is a short video demonstrating the same. This is a case of atrophic rhinitis that we had operated. We had gotten her under control and everything, and we had operated her. And this is 1 month later when we wanted to remove her stent. And this is the picture again. So these cases can be a little challenging to manage, but under a good cover, they can be done well. So we start seeing the stent over here because there is a lot of discharge and crusting. So this is the middle turbinate, the axilla, and our opening over here. So after cutting the stent from the external aspect, we have removed it. Now you can see I'm trying to press the sac, so you can see that movement over there. It's a little deep over here, so you can see the edges very well. There's a small granuloma also sitting on the inferior edge, but this is the opening, if you can see. And there's free flow of dye after syringing. All right, so that was it. So I would like you to take home the following points. One is, it is very important to know the basic nasal anatomy, and that variable positions in the nasal anatomy as well as sac positions are extremely common. And understanding this, especially while you're operating, because you need to take certain subsequent intraoperative decisions accordingly. So that is very important. So you need a good presence of mind while looking at this anatomy. And it's always best to get a hands-on in vivo view before starting out on any procedures per se. Just having a look with your endoscope, even in the OPD or even for your external DCR cases, just prior to operating them, you can just put in an endoscope and just visualize the anatomy. Just make yourself comfortable with the instruments before going ahead. So thank you very much for your patient listening. This is my mentor, Dr. Javed Ali, without whom I would not be the lacrimal surgeon I am today. So I thank him for wherever he has helped me reach. Thank you so much.
Thank you so much. That was an excellent presentation, Richa. Thanks a lot. And we'll move on to the next one. Before we move on to the next one, I'd like to request everyone, if you have any questions or any queries, we are definitely going to discuss it at the end of the session, but you can still put it into the chat box so that they can be reviewed by the speaker and they'll be ready with their replies for you. I request Dr. Snehal to start sharing the screen, please. Hi, Snehal. Yeah.
Is my screen visible?
Yes, it is visible, but not in the slideshow mode. Yes.
Yeah, good morning to everyone. Am I audible?
Yes, very much.
Good morning to everyone. I'm Dr. Snehal Kokuri, Assistant Professor GMC Nagpur. Today in this talk, I'm going to discuss about DCR instrument, which is being used routinely and any specialized instruments needed. I would like to make clear that I'm discussing just about external DCR instrument as the candidates want to know about it. Okay. So we are going to discuss this instrument under this heading, like specialized instrument for DCR, routine instrument, which are usually used for other surgeries also, surgical equipments which are needed for DCR surgeries, and some miscellaneous things. So before going to that, I would like to, many of the candidates would have been discussing DCR would have huge complications or failure rates are more, cannot visualize anything because of bleeding and all those things. But like to make sure that if you have a good anatomical knowledge, as been discussed in previous webinars, if you have good set of instruments and this surgical equipment with you, you are easily can manage any kind of complications or any cases in external DCR with these instruments. So for going towards that, we'll start with this specialized instruments in external DCR. Is Bowman's lacrimal probe. Everyone knows that it is a slender, thin, metallic, blunt end edges, bisided. It comes in a different sizes from 40 to 30. 40 consists of diameter of 0.7 mm as it increases from 1000101 and 4. The diameter of from 0.7 it goes to 0.8 for 30, 0.7 for 20, and henceforth 0.1 is 1 mm is 0 is 1 mm. So and 40 and 30 are usually used for pediatric one, and the 1, 2, and 3, 4 are used for adult probings. As we all know, probing has been done as a diagnostic procedure as well as therapeutic procedures. In diagnostic, we usually do preoperatively just to make sure that the canaliculi are open so that we'll have a successful DCR. If the canaliculi is blocked, at what level it is blocked, we'll have a soft off. If it is a soft off is there, at which level is it? Is it proximal? Is it distal? So if it is proximal, if we can do a probing and clear it. If not, if it is distal, we have to go for DCR. So to get to that point, we have to go for probing and diagnostic. And in cases of congenital nasolacrimal obstruction. So therapeutic probing, as I said, for clearing the blocks. And during surgery, DCR surgery also, we just have to get sure whether we are at the right place, whether we have meeting lacrimal flaps at the level, where the openings are. We have to do a therapeutic probing during that time in DCR surgery. This is Nettleship punctum dilator. It's a slender, single-ended, fine probe dilator, which is of about 0.4 mm oval length. It is around 8 centimeter. It can be there in a double-ended, which is fine and medium taper ends. It is used before doing probing for dilating the punctum before syringing in cases. If not every cases we are able to see the punctum clearly. In those cases where the punctum is smaller at present, we'll go for dilatation, punctum dilator, for diagnosing punctal stenosis preoperatively. During intra-op also, before going for, as I mentioned, for knowing the putting, if we are putting any stent in those cases, we can use punctum dilator before doing probing, and we can put the stent on those cases. Lacrimal cannula, which comes under with different sizes, 22, 23, 24 gauze. Ideal is 23 gauze. It is a malleable. It has a malleable tip and a curved end. So it is used during lacrimal syringing, diagnostic, as well as pre-operatively, as well as post-operatively, to see the patency of the canal or tract. Now this is bone roger forceps. It's a nibbling roger which has a 9 mm opening for the punch. It comes in different sizes, 1.5 to the smallest is 1.5 mm wide. This 1.5 is the width where you are going to punch that bone from the margins of the in the lacrimal fossa and the anterior lacrimal crest to expose the lateral nasal mucosa. And in cases of failed DCR or reoperative DCR where the ostium is small, to enlarge those bony ostium, we punch it from the margins. Now this is a freeze periosteal elevator. It's a long, slender, tapering, double-ended instrument. One end is blunt and other end is sharp. The blunt end is used to elevate the periosteum of the bone before osteotomy, starting from the lacrimal crest. It separates and it's also used during surgery. Once the the periosteum is elevated, once you separate the lacrimal sac, you just have to hold it in that position so that we can have enough space for osteotomy to begin. In these cases, we can use periosteal elevators. It has sharp end also, which is used for cutting or breaking the innominate sutures to initiate the osteotomy. This is waist bone chisel. It has a flat white blunt tip, which is 4 to 6 mm wide. Overall length is 15 to 19 mm. It is used to chip the delicate lacrimal bone to expose the sac and restore the tear flow into the lymph node. It is also used to separate those muscles which are adherent to the lacrimal bone superiorly, where we are going to have an osteotomy. To separate those muscles from those things where the osteotomy is from, because while punching, we can have that muscle attachment together, and that would be difficult to punch that bone. So before going to that, before separating the lacrimal sac, we just have to use bone chisel to separate all those muscle fibers from the lacrimal bone. Now this is Dusto's lacrimal dissector. Long, slender, double-ended instrument. One end is similar to that of periosteal elevator, but this end is larger and is small diameter. It's ideal to separate the sac from the lacrimal sac. And its sharp tip is similar to that of the lacrimal periosteal sharp tip. It's useful to detach the deeper adnexal tissue which are adherent near the duct area, collicular duct area. So now this is cat's paw retractor. This is a very important retractor, which it's a 4 for cat's paw like retractor, which has a bend of 4 to 5 mm or 3 to 4 prongs, which are blunt tips. It's an excellent retractor to retract the skin on orbicularis during DCR surgeries and gives us a good view during surgery. To retract the nasal flaps, after giving a nasal flap, raising the nasal flap, you just have to raise the nasal flap. If you're dissecting the lacrimal soft, if you're trying to put the silicone tube, that time also this cat's paw retractor has to retract the nasal flap separately. It also provides temporary compression to the bleeders while bleeding, muscular bleeders. So now this is these nasal packing. It is used to pack the nostril with roller gauze, which is usually soaked in lignocaine jelly or xylometazoline. Lignocaine jelly is used for anesthetic the nasal mucosa. It also helps in reducing the pain during surgery. And sometimes you can also use xylometazoline if we want a decongested nasal mucosa, less pain. So these were the specialized instruments. Instrument we all know, particle, scalpel handle, which is needed for along with the number being used while giving skin incision, whereas 11 number is needed while having mucosal and lacrimal sac flap. You can also use an 3.2 keratome while giving those incisions. So now the needle loader used for suturing and nasal flap, lacrimal flap, orbicularis muscle, and skin suturing. This is we also need a long and short curved artery forceps. Short is usually needed while after giving a skin incision. We just have to splay those articularis muscle just to avoid and bleeding. We don't cut it, so we just play it with the help of short curved artery, or you can use a tenotomy scissor. And long artery forceps is needed in cases if you're putting a silicone stent. You just have to retract the silicone stent from the from the nostril. You have to use a curved long artery forceps. We need a tooth or a lens forceps, good quality, or a Westcott Caesar, as I said, for dissection orbicularis and deeper tissues and adenic secretion. We need a Westcott Caesar for cutting muscles, trimming nasal mucosal tracts if it is remnant of any lacrimal sacs, and during skin and muscle surgery. Lignocaine spread is containing 10% of lignocaine, which is spread in the on the affected side of the nostril to give an local anesthetic as a local anesthetic agent. Is spread on the affected side prior to the nasal patching. These are now few equipments. If it is not compulsory to have this equipment, but I suggest if you have it, so it would be very good in cases. It helps to stop bleeding in cases if there is blown bleeding, uncontrolled bleeding. It will help you to have proper visualization with less bleeding. So these are the instruments. Now we need sutures. Basically, 6-0 suture is sufficient for external DCR, which is helpful for suturing those nasal lacrimal flaps, skin incisions, and subnodular incisions. But in cases, if you need if it's a pediatric, if you need a good closure, the skin closure should be, I suggest to have a 6-0 Mersil or 6-0 Proling, as these have less reaction compared to 6-0 White. 4-0 Mersil, as in if needed, in cases if you have less hands for assistance, you can retract those and skin and orbicularis or the tissue which you have been retracting with catwalk. You can also use 4-0 Mersil for retracting those things. We also have naps or Muller's retractors, but they are a little bit but difficult to operate all those things because it's difficult to visualize there and put all this thing. Every time retractors get dislodged. That's why I suggest using PATS4 retractor or 4-0 Mersil sutures. Suction machine, again, it's an nothing costly thing. Even cauteries are not that costly nowadays. Basic cautery comes between 35,000-40,000. And suction machines are also available with the metallic catheter of 12 inches, which is suggested for DCR surgery. It helps you to have a bloodless DCR and a clear excision of every tissue, hence avoiding failure of DCR surgery. So now in specialized situation where you have, you think there is some resistance while probing in the distal belt, while opening in the lacrimal sac areas, in those cases or cases where you have post-traumatic DCR or failed DCR or any complicated DCR, in those cases, I suggest to have a proper silicone tube infusion stent, which is a fine thread with silicone tube attached to the two rods, which we put it from the upper and lower curtain and we retract from the nostril and we tie it and keep it for 3 to 6 months as needed. And we remove it after 3 to 6 months. So now this is bone wax, which contains basically bead wax and softening agent. Used to control bleeding from bone surface during surgical process, which is not being controlled by cautery. So in those cases where the bone has been inside or fractured, intra-artery bleed is there, or any damage to the vascular structures near the bone, causing the osseous hemorrhage. In those structures, you can use bone wax, which is very easy to use. You can use that a limited amount of bone wax. It's a mushy thing. You can post it along the bone. It is non-reactive, hence easily metabolized, so can be used in those extensive bleeding cases or uncontrolled bleeding cases. Mitomycin C in cases and chemotherapy agent which inhibits collagen formation, used in 0.5 mg per ml for applied for 5 minutes over the lacrimal and nasal mucosal area, where in special cases where you have failed DCR or there is some intersaxinity or tissue fibrosis or in complicated DCR, where you think there is chances of the flaps being getting attached or adhesions, or the flaps you have cut the flaps accidentally. In those cases, you can use mitomycin. So this is all about the basic instruments for external DCR. So this is the checklist for candidates. You can check it accordingly. You can have a proper DCR. Thank you.
Hello, Shivani ma'am. Thank you, Snehal. It's a wonderful presentation. Now we'll ask Dr. Mantri sir to start his uh, presentation. Snehal, you can stop sharing your screen. Snehal.
Yes.
After the instruments and the endoscopic basic, we are here, Dr. Manpreet, who will be talking about the journey from external DCR to endoscopic DCR. Over to you, sir.
Okay, very good morning to all. Thank you, VOS. Thank you, Dr. Richa, Dr. Shivani, and Dr. Snehal for last Richa and Snehal for their wonderful talks. So my talk is a bit different. I have never given such kind of. It's like I had to make my slides right in the morning when I got up at what is going on inside my mind and what to tell, because this is about my journey. Nothing to be shown as some slides or something surgical. So then I got confused, but I'll try to simplify the things. So it's about my journey from external DCR only when I used to do to endoscopic DCR also. I hope everything is visible. I'm clearly audible.
Yes,
sir.
yes, very much.
So external DCR is still my workhorse. This slide shows that. This slide is a tribute to my mentor, Dr. Muhammad Javed Ali, and he has been a guiding figure, leading surgeon, and who taught us all our oculoplastic fraternity, how to hold endoscope and believe that we can also do these surgeries. And those atlases and the last one, the second edition, which I recently got from him. Thank you for this and for guiding us. So my journey is like, I did my MS ophthalmology in 2010, completed it. My senior residency followed that. It was in oculoplasty in PGI MER Chandigarh. It was for 3 years where I learned external DCR under the mentorship of Dr. Usha Singh, who is currently the president of Oculoplastics Association of India. Then I went into fellowship at Alvi Prasad. It was a small stint, but I happened to be a kind of short-term fellow, but dedicated to dacryology. I learned endoscopic DCR there with Dr. Javed, and followed by that, I went for another fellowship that was oculofacial aesthetics. I went to SSN Guwahati and did it there with Dr. Kasturi Madam. Then I worked as a consultant. I started working finally. And at Sohana Charitable Hospital, it's a local hospital where I used to operate endoscopic DCRs and ENT/OT, followed by my stint, a small stint at a government medical college, state-run government medical college in Punjab. And there also I used to operate in ENT/OT for endoscopic DCR. Finally, where I dreamt of, I happened to be as a faculty at PGI MER Chandigarh. From 2017, I'm working there. And we have a setup there of endoscopic, endovision system. We have got 3 now. So this is like short journey, but what made me learn endoscopic lacrimal procedures in 2014? I'll go back to this slide. So I hope my arrow is visible. I'll make this pointer visible. So here, what made from external DCR to learn endoscopic DCR in 2014? That's what. It was about patients' expectations and demands when I went out and started for some time in private sector. Majority things were from patients. They were demanding scarless surgeries. Patients were demanding, the surgeries which don't give them scars, sutures, and sutureless surgeries basically. I had some self ambitions also to progress into the field, then stand out in crowd and doing something new. Okay, I've been to PGI and you have come out now, what new you are doing. So that what pushed me, but it also I wanted to enable myself to solve the problems. Like when you are a phaco surgeon, you are always sometimes scared that can I really manage my PCRs or posterior capsular rents, and so how to enable myself to solve these problems of revision surgeries? What if something fails? What if my external DCR fails or my probing fails? Then what to do? So then I learned that, okay, endoscopic procedures are one which enables us to look for the cause and then correct it possibly. So why do we need to learn nasal endoscopy? That's why now. Because location of the 60 to 70% of the lacrimal range system, if you look here, it's it's majorly you just remove the this wall. Richa has shown brilliant cadaveric photographs. Remove the lateral nasal wall and you will see lacrimal sac and nasolacrimal duct. Around 60 to 70% of lacrimal range system lies in nasal cavity. We get direct view of the target region, that's sac and nasolacrimal duct. We can analyze the intranasal surroundings, what Richa has shown beautifully, and in her videos, what is happening before surgery, what's there, right from the health of the nasal mucosa. I think that is also very important to look at the health of nasal mucosa, especially in this in northern part of the country. We have high allergies running around. So allergic rhinitis is one thing which we can wait for some time and then operate. To look for functionality of system after performing any kind of DCR. Is it functionally patent? To identify the cause of failure after DCR or nasolacrimal duct probing, I have seen, even chickpeas stuck into the inferior, you can say, turbinates or right in front of the nasal cavities, and removed those chickpeas in children, which may cause whatnot in the nasal cavity. And one of the child was having NLD probing failure. That was a conventional done by someone else. So so to perform various procedures inside the nasal cavity, which can be stent removal or granuloma management, or extended adjuvant procedures like septoplasties and turbinoplasties. So endoscopic procedures are many. If you talk about lacrimal, right from endoscope guided lacrimal probing to nasolacrimal duct intubation, balloon dacryoplasty, endoscopic DCR, stent removals, and then testing those. There are nasal procedures which we can also perform as oculoplastic surgeons. If the sinus mucosal, we can drain it. If it is having some kind of ophthalmic presentation, patients will be presenting to us. Then adjuvant septoplasties, foreign body removals, nasal mucosal grafts for ocular reconstructions. We have been doing it in PGI for our cornea and surface colleagues. Orbit, yes, it has got very good, you can say, indications. Orbital decompressions. Some fractures can also be repaired. Optic canal decompression is one of the coveted one, which one can aim for. And foreign body removals from the orbit can also be assisted by endoscopic procedures, and many more, I hope. And coming on to basic nasal anatomy, which is associated with lacrimal range system. If I want to give you one thing why we should, the nasal cavity is not, one starts thinking it's not that roomy. Look for the roomy nasal cavities in the beginning of your career. It is roomy actually. The only thing is this septal cartilage and alar cartilage, this thing is mobile in everyone like this, this is a mobile tissue. So you can go in with two instruments and manipulate. This is the bony nasal cavity, what you are looking at the picture number 2. This is roomy in all. The front part, the alar cartilage might be, and the opening of the nares, what we call it as external nares, that can be small or large, and depending upon so many other factors. But this is actually flexible. So you can move in the bony nasal cavity via this flexible external nose. Richa has described this, so I'll be skipping this. And applied anatomy is like this middle turbinate. This region and agar nasi, it actually coincides with the lacrimal sac lying inside the bone, and inferior turbinate is, yes, it's definitely associated with nasolacrimal duct opening. These are the images, need not to describe, Richa has already done it. So first things first, the first DCR procedure was performed via endonasal route way back in 1893. So the first DCR was endonasal DCR. It remained less popular, probably because of improper instruments at that time and difficulty in intranasal visualization. Toti in 1904, he described external DCR, and probably that got popular fast. Didn't need much of the intranasal visualization. Nowadays, with the advent of rigid nasal endoscopes, high resolution cameras, and fiber optic light sources, paradigm shift in anatomical understanding has been another thing which has led us to believe in what we see and what we can do. And endoscopic and nasal lacrimal procedures are regaining its popularity. Now, DCR is a gold standard procedure which is taught in ophthalmology and ophthalmic plastic surgery worldwide as external in majority of the places, I can say, which is safe and standardized procedure. However, endoscopic DCR is also currently gaining grounds in the training world also. As it's comparable, it has got a relatively better success rate, even if it's performed by trainees. It doesn't leave any skin scar and all other things, lesser tissue dissection, less intraoperative hemorrhage, and decreased postoperative morbidity, because hemorrhage, you bypass majority of the muscles and vessels from endonasal route. The challenges remain equipment. If you go for full high definition or 4K systems, these are relatively expensive. However, instrumentation is not that a great challenge. Learning curve, yeah, we start doing. I'll show you some of the videos when I used to do it in early years. So this is a newer vicinity nose, but it is it is our neighbor. As we all are orbital surgeons, it's just a neighborhood. Okay, you can go into that. It is just a root. Okay, remember this is a root. Our target tissue remains lacrimal sac. We are not going to fiddle around with the sinuses or what. So be confident that it is just a different route. Our tissue remains same. Variations in nasal anatomy, Richa has described it. We have to be well versed with it if we are venturing into another route. And 2D view is a relatively new thing for ophthalmologists, but for I can say there are 3D endoscopes also visible, but we have to adjust to the 2D views in majority cases. And we need to learn adjunctive procedures in the advanced times, you can say. So coming on to equipment, this image is from one of our textbooks which were published about ophthalmic instruments and surgical tools. Here, this is a typical, this is the patient lying over here. And surgeon typically stands on the right side if one is right-handed, and if left-handed, you can stand on left side. And the trolley should be on the opposite side so that the assistant can hand you over the instruments, and and the eye level and the monitor should be at the eye level of the surgeon, should not be tilted. This is how the endovision system is placed right in front of the surgeon. So endoscope is relatively, it's held basically in the non-dominant hand, and in the other hand, the dominant hand, we use the instruments to operate, and the manipulations are done with the dominant hand. This is how the endovision system looks like. Carl Stores is one of the companies, no financial interests. There are many other, and Olympus, Stryker, and many other. And this is the first system we had in PGI on the picture number 2 on the right side. This is the monitor and the camera unit and the light source. I still use this light source, but the camera unit and the monitor has been changed. These are the telescopes, rigid telescopes of variety Hopkins 2. These are, this is the eyepiece. These are the long rigid tubes which goes into the nasal cavity. At the tip, you have a 0 degree, and the diameter can be 2.7 millimeter. It can be used in the for the diagnostic procedures inside the OPD or even in OT for pediatric cases where you operate for CNLDOs. 4 mm typically we use for DCRs. 4 mm 0 degree, but I prefer 30 degree 4 mm because I tend to avoid or overlook the deviated septums so that I do minimum amount of septoplasties. So this can be disinfected, plasma sterilized, or autoclaved. This image will tell you how delicate this structure is. I have broken one, so that costs around 2 lakh for Karl stores. Then I got to know that there are rod lenses inside, and with the spacer lens arrangements, and this is the field of view what we get from the telescope. So this telescopes basically it actually converges the light and at the eyepiece from where the camera picks up that, and this telescope has another end where the light post is there. Here the light pipe attaches. I'll be showing that. And this is how the tip looks like. Tip of the telescope. This is the objective assembly, and at the periphery in a crescent form, the illumination fibers are arranged at the distal part of the end. So this distal part is very crucial because when you are negating, if you are using 0 degree, then you may not have this crescent. Basically, they are supplied circumferentially. They are arranged, but in 30 degrees in a crescent form. So when we are looking via the DNS, we have to tilt it relatively so that we can get the light bypass that deviation, so that we can get a good image. Anti-fogging solutions like chlorhexidine and cetrimide solution are used. Baby shampoo or povidone iodine rarely can be used. This is what I was talking about. These are 3D and endochameleon Hopkins telescopes are available, which can give us the view from 0 degree to 90 degrees by keeping the same telescope inside. It can give us the 0 degree view as well as 90 degree view. Just keep on rotating this knob here and it will give you this view. This can be used. Light source, I use this xenon light source still, and this is the optical light cable which is attached here, and then the light is conveyed up till this post, and this goes inside the telescope. This is the camera. Earlier we used to have this full HD. Now we have got 4K, and 3D is still waiting. This is the camera head basically, and this wire goes into the camera system. So this is how the final attachment looks like. The telescope goes here and the optical pipe attaches over here, and this is how the eyepiece is connected to the camera. This is another instrument, Decryo endoscope, which can give you a good view of the intracanalicular, actually the lumen of the canaliculi as well as nasolacrimal duct. It's a good handy tool if you have in your armamentarium. This is a flexible eyepiece over here. So this is the rigid endoscope, which is 0.6 millimeter, and it has got one illumination arm, and this is the port of irrigation to clear the view. These portable endovision systems are available. They are relatively cheap, around 2.5 to 3 lakh. You can manage for a decent one, which you can carry in your car, and if you are operating in various hospitals and doing freelancing, that's a good handy tool. These are the instruments for a DCR trolley. I'll not go into that. Powered tools are available, which makes a surgery very easy, and sometimes we need these because the superior part of the bone, which is not punchable, your punch can't grab that. So there you need to drill, and sometimes you may need microdebriders for those bullas. So coming to this article which I got, this is an experience actually of a fellowship trainee at a tertiary care center, published by my dear friend Saurabh. He's also a long-term fellow of LV Prasad Institute. So this is the last paragraph of his article, that all disorders pertaining to the lacrimal drainage apparatus fall entirely within the domain of ophthalmic plastic surgeon. these are the times, 2016, 2014, when people were debating that should we, as ophthalmic plastic surgeon, should we go into the nasal cavity and, start operating? Probably some complications might be there, cross specialization and all. So then they made it clear that falls entirely within the domain of ophthalmic plastic surgeon, and therefore we believe endonasal DCR is a surgery that the ophthalmic plastic surgeon should be competent in and confident about. Endoscopic DCR has excellent anatomical and functional success rates in hands of trainee. A structured training program, thorough knowledge of nasal anatomy, clear demonstration of surgical steps, supervised by experienced surgeons, result in efficient skill transfer. That trainee surgeons require more surgical time in early phase of their learning curve should be recognized. We believe the findings of our paper could help formulate a structured curriculum in ophthalmic plastic surgery fellowship programs, especially in view of increasing use of endoscopes in ophthalmology. So this was in 2016, early 2016, so must be written in 2014 or 15. That's a good paper, made us more confident. So talking about some limitations of external DCR, what I really found difficult is because I am only having the best possible view. It's a tunnel view. To the assistant, it is not clearly visible what exactly I want to show sometimes, because they have to move around and really look into what angle of the view what I'm trying to show. Illumination and recording are not exactly what we see. And the dissection of orbicularis oculi muscle is one thing which sometimes we don't want to, but advantages are if we have lacrimal sac mass palpable. And what this recently I have found that traumatic anterior displacement of medial canthal tendon. In SALDO cases, if the medial canthal tendon gets displaced anteriorly, so in those cases, when I try to go via endoscopic route, I need my instruments for going quite anteriorly, and for that it was getting difficult, and for keeping the view of the endoscope, actually it was getting bloodstained frequently. So then I thought, okay, because we have got a bit of more workload here, and when I started doing external routes, the success rate also improved. And in anterior displacement of medial canthal tendon, there are relatively different things which can happen with the stents and the issues. The limitations of external DCR will be in this lacrimal sac abscess, or fistulas, dacryocutaneous fistulas, where you are really confused where should we give the incision, as well as acute dacryocystitis cases. Yes, definitely we can go via endoscopic endonasal route. These are the advantages. The most important one remains preservation of lacrimal pump. There is no incision over the orbicularis oculi muscle. This point is valid for the surgeon. For the patient, it is faster recovery, minimal morbidity, and higher patient satisfaction. What I believe as a teacher, the viewing, demonstration, and video-based coaching via recordings, that's the best possible advantage of endoscopic endonasal DCR. As a teacher, what we are seeing, actually everyone is seeing that only. Overall reduced operative time, with time you reduce that, addressing the nasal issues and minimizing the failures, lesser intraoperative bleeding, yes, and there's no scar, okay, possible in lacrimal sac abscesses, dacryocutaneous fistulas, and dacryocystitis, as I've shown in the last image, last slide. The minimal post-operative medications are also, you can, you don't need any, actually, just Combiflam for 3 or 4 days, what I use, and topicals I do, and definitely the nasal sprays. So the challenges for beginners remain that the nasal septum deviation is, if it is towards the operating side, then there is difficulty in visualization, and instrumentation also sometimes is challenging. You may end up in creating more damage and creating more septonasal lesions. Otherwise going via external DCR. Posture training is one. Dr. Javed, I remember he used to have some neck pains. I started developing in the beginning of my career, when I used to look up towards the screen sometimes. So that you need to learn over time. Instrument handling, avoid multiple entries, and special attention to superiorly based bone which is overhanging the ostium. and using powered instruments. Powered instruments basically makes your life very easy. So these are the some challenges to the beginners, but with time you will definitely recover this. This is the best slide of my presentation, if you want to say. These are the three phases in which the step-by-step training for endonasal procedures can be divided. The first phase is thorough understanding of nasal anatomy. Richard taught us very well. Hand-eye coordination, develop a good knack of it. Maintain correct posture if you want to really operate and your follow-up or if a long surgery list is there. Achieving dexterity, maneuvering during initial surgeries is very important. Don't repeatedly come in and come out of the nasal cavities. The second phase actually, demands, it recognizes anatomical variations. Richa also showed that beautifully. Achieve adequate superior osteotomy, which is empowered with the powered instruments. Complete sac exposure, 360 mucosal approximation, identifying and managing intra-sac pathologies like sac granulomas or some pre-existing scars or adhesions are there. Handling additional instruments, that's ultrasonic or diamond tip buds. This is the second phase. In third phase, one can go for pediatric DCRs, failed DCRs, bilateral simultaneous DCRs. I actually don't do it, but one can. Adjunctive procedures such as septoplasty to make the operating space roomy. These are few videos. If the time permits, I can show one or two.
Please go ahead.
Should I show all, like 4 or 1 is good enough?
I think yes, we can.
Then
Are they very long videos?
No, short ones all.
Yeah, we can go ahead. Please do.
Okay, then I'll show the lacrimal probing for CNLDO. I hope the video is visible.
Yes.
Okay, so this is a kind of a complex CNLDO where we went under the. I actually do all my probings under endovision guidance only. So this is persistent CNLDO in a complex variety of split hand and split foot syndrome. It's a Bowman's lacrimal probe goes in. In previous, actually this child was having cannula in her feet when she came. She was having acute dacryocystitis. So the earlier procedure was done under, I think, mummification by holding the child and under local anesthesia, topical only. So when we do it under general anesthesia, this is the right nasal cavity. You can see this inferior turbinate was impacted, which we have just medialized. After medialization, the things becomes clear, and you see how I'm holding now and the probe is getting pushed here. But when it is under visualization, the surgeon is confident to push it relatively harder, even in a complicated, hard, soft palate agenesis. So this is the expression of mucoid fluid after, recovering or perforating the obstruction. This is the left side of the same patient. Here also, for a stretched mucoperiosteum, you can see, yeah, it has overcome, and multiple openings. If you can make a 45-degree probe tilt test, if there is a nasal cyst, evacuation of the contents. And I wanted to share that thing that if this patient was having cleft lip, cleft palate along with, when we are doing it under nasal endoscopic visualization, you are confident for how much pressure you want to give to perforate. And in conventional probing, probably you might not be confident, especially in this kind of complicated scenarios. So this enables us, actually empowers us to go for the endoscopic guided probings in all the children, what I do. And a small one for buried probe. This is another variety where we need to manipulate actually. So this is a left side nasal cavity. You can see the probe moving beneath the nasal mucosa. This is the inferior turbinate. And here it's reaching till the floor of the nasal cavity, but it's not opening up. So this is the buried probe variety. It's still under the mucoperiosteum. So what we do, we need to create one opening here, a cruciate shape opening with the 11 number blade, or what I usually use now these days is the 15-degree phacocyte side put. And a couple of slides left. How learning endoscopy has empowered me. You become more confident while performing lacrimal probing and CNLDO. Adjunctive procedures like balloon acryoplasty and nasolacrimal duct intubations are doable then. Postoperative DCR ostium monitoring, the management of granulomas and stents are, they're very important for ensuring the success of your surgery, be it external or endoscopic DCR, and confident and better management of the failed DCRs. Endoscopic decompressions of orbit, it seems doable, and optic canal seems possible in future. So the take-home message is start early. It's already happening. Start visualizing nasal cavities. Begin with diagnostic nasal endoscopies in your clinic and nasal packings, post-operative evaluations. Even if you perform external DCRs, the minimally invasive surgery is the future. People are demanding it. That's what compelled me to go for this in 2014. These days, everyone actually, be it any government setup or private people, ask for this. And these are the basically patient-focused interventions. Your patient is actually having majority of the benefits rather than you yourself actually. 3D endoscopic systems, image-guided surgeries, and intraoperative blood vessel analysis are the, you can say, the future tools or research tools which enables you to see what is happening into a specific kind of situation and try to figure out what is the possibility in this case, or will it fail or will it succeed this surgery. And another things like deciphering what is causing the nasolacrimal duct obstruction, and it opens definitely more horizons like orbital decompressions and whatnot. And thank you for your patient listening.
Thank you so much, Dr. Manpreet. It indeed was a very informative journey from external to endonasal DCRs. So thank you very much for being here with us. Let's open the floor for any question and answers which anybody would like to have. I think I can see a couple of queries which have been put up on the chat. So Dr. Kavita wants to know whether endonasal DCR done by an ENT surgeon, is it the same as that has been done by an ophthalmic plastic surgeon? So either Richa or Dr. Manpreet, if you'll be able to answer that.
Dr. Richa, go ahead. Then I have to.
Yes.
Hi, Richa. Go ahead, please.
Hello. So Dr. Manpreet actually covered that part beautifully about the advantages of endoscopic over external. Basically, it is about patient preference. That is one thing. Secondly, the only actual clinical indication is related to acute acrocystitis or lacrimal abscess, where external DCR would be contraindicated. And third is the surgeon comfort level. So other than that, pediatric DCRs is something I would prefer to do endoscopically rather than externally, because anyway, you have to give them GA. And I don't know how Dr. Manpreet does it, but as per my training, I have learned endoscopic DCRs only under GA. So I unfortunately can't do it without GA. So I am handicapped that way. I believe a lot of ENT surgeons do perform endoscopic DCRs under local anesthesia as well. But that brings me to the second question. I believe somebody has asked regarding ENT surgeons. Endonasal DCRs done by ENT surgeon, is it the same? So see, first of all, every surgeon will perform the surgery differently. So we really cannot predict that. But according to whatever failed cases that I have received in the OPD, done previously by ENT surgeons, few I have noted, I have performed external DCR in those cases. So few I have noted that the bone was not addressed at all. Now, if an osteotomy is done, even a decently big osteotomy is done, there will be some amount of bone opening that is present even after bone healing. It won't be completely closed. So maybe the anatomical variation was there and they did not pick it up. I don't know what it was. Secondly, I have also noticed a few endoscopic cases where I have evaluated the DCR ostium that after opening the sac, because it's easy to raise the nasal mucosal flap and remove the lacrimal bone inferiorly. And then what you're seeing is probably the nasolacrimal duct junction and the inferior part of the lacrimal sac. So I notice what they usually do is they incise that and they do syringing intraoperatively. They see that the dye is flowing and then they close the case. So it's not what we are achieving to do when we are trying to do an endoscopic DCR. We want a complete superior clearance, like Dr. Manpreet very nicely explained, that the superior part of the ostium, where our common canalicular opening actually lies, that needs to be exposed very, very well. Otherwise, you're going to face some amount of failure. So, Dr. Manpreet, if you have anything to add.
Yeah, I can add 2 points here. One thing is the repetition. So I've been called upon by some ENT surgeons, like how do you do the DCS when I was operating in ENT OT. I was using their equipment, so they were there to see it. And so what they usually do is inferior DCR. They basically target the nasolacrimal duct junction, or probably sometimes they open up the the ostium or osseous part of the nasolacrimal duct only, and they don't go till the superior part, which actually was it's very important to expose the sac completely and marsupialize it completely. That is important, what Richa has covered. So one thing is they do relatively inferior DCR. And if you have noticed, Richa, what we do is we try to sacrifice, or we tend to sacrifice sometimes, nasal mucosa. What ENT people do is they tend to preserve nasal mucosa. They tug it in the middle meatus, and then they sacrifice lacrimal sac mucosa. And they try to make the ostium lined with the nasal mucosal flaps. So here the lacrimal sac, and it is like a frill of the lacrimal sac only is left by the ENT surgeon. We don't actually sacrifice any part of lacrimal sac. So what they do is they tend to sacrifice lacrimal sac, and then they cover the ostium with the nasal mucosa. That's one thing which I saw, and which I expressed that it can be avoided to have a better functionality of the system.
And do you perform it under GA or LA?
Yeah, I am also trained via same. I do all the surgeries endoscopic DCR under general anesthesia.
So what about the cases that are high risk with respect to GA? Like, do you convert them into external, or do you do a modified?
Absolutely. We have to go ahead and we have to give the patient what they want. Majority of them are waiting for their cataract surgeries, and we have to do.
Yeah.
So I have one question. When I was at LV Prasad Bhubaneswar, I had seen an assisted Dr. Suryasnatha Rath. He used to do an NEN DCR, that was a non-endoscopic endonasal DCR. So what are your views, both of your views regarding that?
I think Richa is the best person for that. I've not seen him operating. I've read a lot about it.
It was a very, very difficult surgery to perform.
So I was a Hyderabad fellow primarily, and I went to Bhubaneswar after a decent amount of training in Hyderabad under Dr. Javed. So after seeing so much of endoscopic surgery with Dr. Javed, and even performing a few steps before going to Bhubaneswar, I honestly found it a little challenging, because I'm like, if you have an endoscope, it is so easy to visualize everything. Why am I doing this with such difficulty with the loops? So, but having said that, Dr. Rath and Dr. Mohapatra, they do it really well, and they have very good success rates. They have a couple of studies about it also. In fact, Dr. Rath had expressed his displeasure about me being the only fellow not being able to learn that surgery before leaving his posting. So I think the reason for that was because I was already swayed towards Dr. Javed's surgery.
I think that's a Caldwell approach, and it is to enable. It's like SICS of Lacrimal, if you want to put in
Perfectly
simpler
put,
words.
perfectly put, I would say. But I always thought it was a very challenging one. And
It's
this
challenging, but if
it
you
is.
learn it well, I think it's doable. And but however, if endoscope is lying in your OT, then why not to use it?
I understand. So we have a question from Dr. Chitra Pandey, ma'am. She wants you to let her know guidance for removal of superior bone during osteotomy.
Yeah, all the questions are for you.
Okay. So sometimes that superior bone is basically the thick frontal process of the maxilla. So many a times, ma'am, we cannot insinuate our bony punch. Like even in an external DCR to do the superior most osteotomy, sometimes we need the largest punch and we need to make sure that we take the entire thickness within our punch before we go ahead. So these give a little technical challenges when we are actually, putting that instrument through the nose and trying to maneuver those angles. So I prefer to complete my superior bone by drilling, using a powered drill usually. But if you don't have a power drill, like you can use even a mechanical drill with a separate system. Otherwise, the M5 is the best. What are your views?
Yeah,
Dr.
just adding on to that, I think when it is actually not punchable superiorly, and we should not try to do that. While trying to do that, you can actually create a fracture which can extend superiorly, especially in pediatric cases. So it is best if you don't have, then try to shave it off or use Dr. Raman Malhotra has got a angled punch. He has described one. It's a mechanical tool, get it, and you can do a superior good osteotomy. I think that it is actually a bone nibbler, which we use sometimes for orbital surgeries, and it is angled one. It's a small one to go into the nasal cavity.
So there's one more question. Have you ever faced any complications of endonasal DCI when you had to refer the patient to an ENT surgeon? Any one of you?
Yeah, go ahead.
I haven't yet faced anything like that.
Me too. Not ENT support is not always needed actually. Probably once when I was fellow, we had a bad sphenopalatine artery bleed. It was a traumatic case, saldo, and it was bleeding a lot actually. So we tried to pack and ended up packing both nostrils and a throat pack also. Then I was made to rush to the multi-specialty hospital. That thing only, and while ENT also didn't do anything, he was also like looking at, okay, packing is done, and we'll see. They also wait for something sinister probably, but the patients are mostly all right. We don't usually need it if we actually limit ourselves to our vicinity.
So mostly
So
never.
actually, I just want to, yeah, please.
No, you go on, you go.
No, I just want to add that complications would be related to intraoperative things. Like one of the examples I showed was the middle turbinoplasty. Basically, lacrimal surgeries lie quite anterior if you see the entire length of the lateral nasal wall. So anything that is interfering with that particular area, say a very severely deviated septum, narrowing your cavity so much that you cannot even put your scope to move your instruments around, or a middle turbinate that is sitting over there and that is going to obstruct your ostium if you create one. So, but learning those surgeries like a basic septoplasty and a middle turbinoplasty, if during your training, if you pick up those kind of cases and you end up learning them, then I think those basic complications, I can't call them complications, but variations you can manage by yourself. But if you feel you are not competent enough, maybe you can get an ENT surgeon with you, along with you, to do that also. That's fine.
Yeah, in the beginning, this it's kind of a win-win situation for both. They also learn when you are operating. They also learn so many things, and it's win-win situation. How they use ADR in and out, like it's really. And Richa, can I ask you one question? Which
Sure.
endoscope you use basically? 0 degree or 30-degree telescope?
0 degrees, 4 mm 0 degrees. I don't use the degrees.
So I was also trained by Javed for 0 degrees only, because that gives you exactly what we are looking at. However, I have shifted myself to 30 on my own, because whatever is presented to you from the by the monitoring, we are looking at the monitor. So whichever angle, so you tend to basically overlook those grade 2 to grade 3 infected DNS, like it is doable. So once the screen shows me it is okay, there's not much of a DNS. I've got 0 degree in my diagnostic region and OPD, but I operate with 30 degrees. So that's what, if you can also incorporate and try to see, you may end up doing lesser number of cephaloplastics.
I'll try that definitely.
So we have one more question from Dr. Preeti. She wants to know if she wishes to start diagnostic endoscopy in OPD. Is there any budget-friendly equipment, a specific company any one of you could suggest?
So
Richa.
the ideal one would be a portable one that Dr. Manpreet showed. They even have HD systems nowadays where it's a very good visualization, good screen. The best one would be Stores, which is a telepack. But that is also quite expensive as compared to a few local companies. There are a few local companies in and around Nagpur, Dr. Preeti. So they are selling that particular equipment for around 1.5, I would say, along with the endoscope. So you can get it. It incorporates everything. It has the except endoscope you have to buy separately, obviously. But other than that, all your camera head and the light source and your display, those are the 3 basic things that are required. They're all there.
These are indigenous made and very nice. You can operate any of this.
So any more questions, anybody? I don't see any more questions in the chat box also. So before I hand over the mic to Milind for concluding, I'd like to just put in one word of appreciation for Dr. Snehal. Snehal, it was a very excellent discussion on all the instruments which are required for doing this surgery. And thank you so much for your presentation. So I'd like Milind to take over now.
Hello everyone. Dr. Manpreet, Dr. Richa and Dr. Snehal, it was a very good presentation and thorough discussion. That basically it is not to scare everybody about the endoscope, but to learn that what we want to, what we can achieve if we go step by step, and what we have to accept from the ENT person, because in 70% this ENT surgeon operate in ophthalmic practice, and they have their own agenda which they push on the ophthalmic surgeon that this is the way we have to operate. That you can suggest them this few adjustments so that the failure rate which you have to explain to the patient can be minimized. So also this is the initial thoughts that you can learn the endoscope if you purchase it, and you can go ahead with seeing many ENT surgeons doing DCR in your own OT, and you can start the endoscopic visualization of structure, and later on you can it also supplement you for the external DCR to know the cause of failure and build a different anatomy which we generally miss if we don't do the endoscopic evaluation. So there will be the endoscopic evaluation part in our cadaveric dissection also. So this is nothing but a small brief what we can discuss on the day, and all those candidates who will be present while in cadaveric workshop will have the similar type of discussion. Thank you behalf of VOS, OSN, and all our Oculoplasty group, Dr. Manpreet and Dr. Richa.
Milind, before that, Dr. Chitra Pandey ma'am and Anup is also here.
Yeah.
So any of the panelists, they would like to put in a word? Anup or madam, would you like to add in few of your experiment? Yes, madam is there. Madam, would you like to share in some of your experience?
It was very informative and excellent session. I congratulate you all. Thank you for inviting me.
Thank you so much.
Thank you, ma'am.
Would you like to? Anup is there? I don't think he's right.
Yeah. Most of them are in Chekala.
Okay, fine. So
Yeah.
I guess this is Tata bye-bye from our side. Thank you so much, Dr. Manpreet, Richa, Snehal, and see you all again on 18th of August. Okay?
Okay.
Bye-bye.
Thank you.